Hello, everyone. I'm Dr. Arash Fazl. I'm a neurologist at Wood Gardner Parkinson Care Center at Evergreen Health in Kirkland. And I would like to thank Northwest Parkinson Foundation for giving me the opportunity to present at the HOPE conference. And the topic that I will review with you is motor fluctuations in Parkinson's disease. In way of introduction, I did my residency in neurology at Mount Sinai Medical School in New York, then did my fellowship in movement disorder and Parkinson's disease at NYU in New York City, worked on the East Coast for a few years, and now I'm at Wood Gardner Parkinson Care Center at Evergreen Health in Totem Lake, Kirkland. And if you'd like to see me, here is the address. So in way of introduction to Parkinson's disease, it's known to mankind for centuries. In ancient civilizations in India, it was called Kampavata in the texts of 500 BC. In 1817, Dr. James Parkinson first described the symptoms of this disease in his article, Essays in Shaking Palsy, and gave its name. Chemical differences in the brains of Parkinson patients were identified in the 1960s. And Parkinson's Disease Foundation was established in 1957, and later Michael J. Fox Foundation was established in 2000. Here in our area, Northwest Parkinson Foundation was established in 1998 to bring Parkinson care to the Northwest. And after several years of advocacy and fundraising, Northwest Parkinson established the Wood Gardner Parkinson Care Clinic at Evergreen Health to improve the quality of life for patients and families living with Parkinson's disease. Wood Gardner Parkinson Care Center is involved, I'm proud to say, in several cutting-edge clinical trials for treatment of Parkinson's disease. So, what are the symptoms of Parkinson's disease? It's a very common neurological disease. It usually starts around 60 years of age, affects about 1% of the 60-year-old population, but its prevalence increases exponentially, such that if you look at people around 80 or 90 years old, 10 to 15% of them can have Parkinson's disease. We think that it is caused by an interplay of genetic and environmental factors. It affects both motor or movement and non-motor functions of the brain. Many symptoms of Parkinson's disease can be attributed to the loss of dopaminergic neurons in the brain and decreased dopamine production in the brain. The motor symptoms include rigidity or stiffness of the muscles, slowness of the movements, of voluntary movements, a resting tremor, and sometimes gait and balance difficulties, also speech or other motor difficulties. As I said, there are non-motor symptoms as well, including mood, memory, motivation, pain, etc., that can happen in Parkinson's disease. When you look at the progression of Parkinson's disease, when the movement symptoms start, we call it the onset of Parkinson's disease. And they are the slowness, bradykinesia, rigidity, tremor, and it can progress. But also before the start of the motor symptoms, many patients experience non-motor symptoms such as REM sleep behavioral disorder, acting out their dreams, depression, anxieties, increase of constipation, hyposmia, or difficulty with sense of smell. And as disease progresses, you have appearance of some complications of the movements, such as motor fluctuations and dyskinesias, which is the topic of this talk. And then later on in the disease, you can experience postural instability, falls, gait disorders, swallowing difficulties and postural or axial deformities. On the non-domain side, you can have somnolence, fatigue, mild cognitive difficulties, experiencing different types of pain, urinary symptoms, drops in blood pressure, orthostatic hypotension, psychiatric symptoms like visual hallucinations mostly, and higher degrees of cognitive decline. How do we diagnose Parkinson's disease? The diagnosis of Parkinson's disease is primarily a clinical diagnosis when a neurologist specialized in movement disorders preferably detects telltale signs of Parkinson, including slowness of the movements, rigidity, and resting tremor in the physical examination. If the clinician is in doubt, he or she can utilize two tests to confirm the diagnosis. One of them is called a dopamine transporter or DAT scan, where these dopaminergic neurons can be highlighted using a radioactive tracer. And if their numbers have gone down, we can see in the brain, and that is a sign of Parkinson's disease. As you can see, the posterior parts of these brain area doesn't have much uptake compared to the normal subjects. A second newer method of diagnosing Parkinson's disease is using a skin biopsy and look for a bad protein called alpha-synuclein. This is the protein that we think causes Parkinson's disease by injuring the neurons, and we can not only see it in the brain, but also in the skin, and that's where we find it, and we can diagnose patients with Parkinson's disease. This skin biopsy is newer in the past couple of years. Clinicians are starting to use it, and it's an easier test to do. Now, what medications do we have to treat Parkinson's disease? I should say that many motor symptoms are due to the lack of dopamine in the brain. And Levodopa is the major classic medication that we have for treating Parkinson's symptoms. It goes to the brain and converts to dopamine. So Levodopa can go and gets picked up by these dopamine neurons, converted to dopamine and released, and basically make up for that deficiency in dopamine. There are other mechanisms that can help this central piece, and these are the medications that affect those other mechanisms. There are medications that affect this enzyme called COMT. These are COMT inhibitors that can stop the levodopa from breaking down and make it last longer. Examples are these medications, entacapone, Stalevo, Ongentys. There are medications similarly called MAO-B inhibitors that they also stop the breakdown of dopamine through another mechanism, and their examples are rasagiline, selegiline, safenamide, Xadago. There are some medications that, without actually changing to dopamine, they mimic the effect of dopamine on the brain. They're called dopamine agonists. And there are another big class of medications used for treating the symptoms. Examples are pramipexole or Mirapex, ropinirole or Riquet, rotigotine or Nupropatch. And there are some medications that are in separate classes. They don't work through these central dopaminergic pathways. Examples are amantadine or its long-acting versions, Osmolex or Covri, or Nourion's istradefylline. But the major medications is the Levodopa medications. You have heard the name, most likely Carbidopa, Levodopa, or Sinemet is the pillar of treating symptoms of Parkinson's disease, and some of its other preparations like Levodopa or Inbrija, and we will go to those in more detail. Okay, so now that we have learned Levodopa is the mainstay, is the most important medication, in treatment symptoms of Parkinson's disease. Now we can go to the concept of motor fluctuations. As you take individual doses of levodopa, for example, every 4 hours at this times, signified by these black arrows, the dopamine levels in the blood and in the brain rises and falls. You take another pill, it rises and falls, so on and so forth. And the early on in the course of the disease, in Parkinson's disease, the brain tolerance for these fluctuations of the medication is quite high, meaning wherever level of the medication falls in this green area, the brain is okay and the medication can treat the symptoms of Parkinson's disease. However, later in the course of Parkinson's disease, the brain tolerance window, this green area, for dopamine narrows. And as a result, sometimes the same amount of levodopa that in earlier years was tolerated might be too much for the brain, and it causes excessive movements, sometimes called dyskinesia, or it's too little, and it is not able to cover or treat the symptoms of Parkinson's disease, and the result is wearing off or an off time. And it's important to see that this is not because of some dynamic of the medication. It is because the brain and its response to levodopa changes as Parkinson progresses. So it's not, it has been shown that these changes do not happen because patients started taking Sinemet or levodopa too early in the course of the disease or took too much of it. It basically is a property of the disease and not because of the medication. So starting levodopa later, hoping to spare these side effects and avoid motor fluctuations in future, are therefore ineffective. Still in clinic, some doctors believe that delaying the start of levodopa can save the patients down the road from these motor fluctuations, but that myth has been debunked, and we don't think that it helps. So it is quite common. These motor fluctuations are common. Dyskinesias or excessive voluntary movements usually happen at the peak of these levodopa doses. And as you saw, the off periods or increase in PD symptoms happen at the trough of levodopa doses. And the fluctuations happen in 40% of the patients within 5 years of disease onset. And after 9 years, they are as common as 70% of patients experience them. In a Michael J. Fox survey of more than 3,000 patients, 70% of them reported experiencing off times, and it was mostly more than 2 hours a day. So even though it's so common, physicians can miss their presence in nearly 50% of these patients who have motor fluctuations. So it's common and it's underdiagnosed. It's important to mention that some patients also experience fluctuations of their non-motor symptoms. So it's not only limited to their movements, they can experience worsening of their anxieties, of their mood, which is the most common. Some can experience urinary urgency or abnormal breathing. So it's not only in the motor domain, but motor fluctuation by far is way more common than non-motor fluctuations. So how do we treat them? The first strategy is, of course, taking Carbidopa, Levodopa, or Sinemet at shorter interval. And if needed, you can decrease individual doses so that they don't get too close and their peak doses increase and causes dyskinesia. That's the simplest strategy used first. We can use longer lasting preparations of levodopa. We will see which one are these preparations. We can take additional fast-acting medications to overcome or rescue an off period. Or we can add other classes of longer-acting medications to the levodopa regimen so that when the levodopa wears off, these medications are there to avoid a severe off time. And in more advanced treatments, we can use continuous infusions of levodopa or other medications. And finally, another advanced treatment is deep brain stimulation, or sometimes MR-guided focused ultrasound ablations. We will have a look at individual items in this list in next slides. So a very common strategy, common medications, are those preparations of levodopa that extends the durations of its action. Longer lasting forms of levodopa exist. Most commonly, you have heard of Sinemet CR, continuous release, or ER. They do not last much longer than the classic levodopa. If this is the classic levodopa, Sinemet CR releases on this yellow curve, so slightly longer acting. Another preparation is using entacapone or opicapone, a newer version of that chemically slow down breakdown of levodopa, so it lasts longer. A brand name called the Stalevo is basically Sinemet plus entacapone in one pill, and both of them enable slightly better, slightly longer lasting half-life of levodopa to happen. And finally, Rytary is a capsule that contains different time release beats of levodopa. So there are a few fast-acting beats that release very quickly. There are some intermediate beats and some long-acting beats that take quite a while before they wear off, and using these longer acting versions of levodopa enables us to maybe not decrease the interval between doses of Sinemet too much. So if you remember in this previous slide, I told you that there are other classes of Parkinson medication other than levodopa. A lot of these classes have longer half-life than levodopa. And we can add them on top of the levodopa Sinemet regimen and have the patient tolerate the off times better. Examples are dopamine agonists, pramipexole, Mirapex, propranolol Riquet, or rotigotine, Nupro patch. We can add selegiline, rasagiline, or Zadago sulfonamide on top of the Sinemet, or other classes such as amantadine and its longer-acting versions like Osmolex and Gocovri. They not only have a longer half-life, they can also diminish dyskinesia quite successfully. And also Norion's another medication that can help keep the off times from being too deep and the symptoms improve during those periods of levodopa decrease. Then we have these rescue therapies for off times. The concept is that if levodopa decreases and patient feels that an off time is coming, they use this very fast-acting medication and bridge the gap between doses of oral levodopa. An example is Inbrija, which is an inhaled fast-acting version of levodopa that doesn't go through the gastrointestinal tract. It is inhaled, so it goes through the lungs and directly absorbed to the bloodstream and gets to the brain. So it kicks in within a few minutes, And using it enables the patient to cover that off period and make it to the next dose of oral levodopa. In a similar concept, we have injectable apomorphine, which is a dopamine agonist, that, again, when the patient feels that one of the off times is coming, injects a dose of this apomorphine, acts very quickly, goes to the bloodstream right away, and gives the patient opportunity to make it to the next dose of levodopa. A newer preparation of apomorphine exists. It's sublingual, doesn't require self-injection, and it's easier to use. Same concept, directly absorbs into the bloodstream under the tongue and doesn't go through the GI tract, so enables us to patch the off times in between doses of levodopa. Now, in all of these treatments, the main source of medication for the patient is the oral levodopa. We sometimes extend it, we sometimes patch it with these fast-acting rescue medications, but still, we have to rely on the pills or capsules of oral levodopa that release all of their contents in this explosive manner every few hours. And so it is hard to expect it to act continuously as we expected. So because of that, they have invented this system called Duopa pump, which delivers a liquid form of levodopa, a suspension liquid form of levodopa, continuously around the clock to the body. In order to do it, the doctors, usually the GI doctors through an endoscopy or radiologists, need to insert a tube into the stomach through the abdominal wall, and its tip goes through the small intestine and sits in the first part of the small intestine. That's where the levodopa gets absorbed. And this pump delivers continuously, every minute, a small amount of levodopa and takes out this pulsatile component of oral medication. And as you can see, if this is the blood level of levodopa, it remains pretty constant during the 16 hours that patients usually use this pump. Patients start it in the morning, and very quickly it gets to the levels that overcomes their symptoms, and it remains at that level very tightly, very religiously, all the way until they stop it and it gradually goes down. Hopefully, this is when the patients have already slept, they don't need it. And so it's one of the very successful ways of overcoming motor fluctuations. So far we have talked about chemicals, medications, and we know that all medications in the market eventually have some side effects. And in the course of Parkinson's disease, patients usually need to increase their levodopa dose or add these other mentioned long-acting medications on top of that, and as a result, might experience side effects. Higher doses of Parkinson's medication can cause visual hallucinations, drops in blood pressure, nausea or vomiting, impulse control problems such as gambling, obsessive eating, hypersexuality, dyskinesia is excessive movements, somnolence, constipation, and several other side effects. And it is not unusual for patients to take other medications to treat these side effects of levodopa so we can continue the levodopa regimen. And deep brain stimulation can sometimes decrease the need of patients for levodopa and improve the side effects of levodopa. So let's look at the deep brain stimulation, which is another modality used for motor fluctuations. So what is deep brain stimulation? We use deep brain stimulation not only in Parkinson, but we have used it safely, and it's a standard of care in some other movement disorders, such as essential tremor, dystonia, or Tourette syndrome. We have had good results. Obsessive compulsive disorder and seizures, they have been tested and FDA approved for all of these disorders. How does it work? In order to understand how DBS works, we have to go deep in the brain, literally, and look at a group of neurons called basal ganglia that form a complex circuit deep in the brain, and they control the planning of the movement and carrying out of these plans. Basal ganglia select a suitable movement plan when we need to, and stop all the other unsuitable ones for that moment. For example, if a patient wants to hold on to a cup, he or she needs to engage one hand and not engage the other hand or the legs. So that's where the basal ganglia kick into action and select an appropriate plan of action and carry it out. When you have lack of dopamine in Parkinson's disease, parts of basal ganglia get hyperactive and slow down other motor areas. They suppress other motor areas in the basal ganglia, and deep brain stimulation jams these hyperactive centers and restores balance in the circuit. Common targets that we use for deep brain stimulation are subthalamic nucleus, globus pallidus, pars interna of basal ganglia, and sometimes thalamus. It sort of works like a pacemaker for the brain. It tones down the excess activity in these targeted areas. This electrode is connected with a wire under the skin to a battery or pulse maker, pulse generator, that, like a cardiac pacemaker, sits under the skin of the chest. Everything is inside. So which patients benefit from the surgery, and who do we recommend DBS to? We choose to discuss deep brain stimulation with those Parkinson patients who respond well to levodopa, meaning levodopa still works for them, but experience motor fluctuations or side effect of the medications. So as you can see, it's a very common problem in Parkinson's disease that DBS can solve. And we prefer that patients don't have a severe cognitive problem. Mild cognitive problems are okay. They do not have severe depression that is not controlled with medication, or otherwise can undergo the surgery. Also, not all symptoms of Parkinson respond equally well to deep brain stimulation. It works best on tremor, on the rigidity or stiffness, and on the slowness in Parkinson's disease. And similar to medication, deep brain stimulation helps less with gait and balance issues, or with speech and swallowing and non-motor problems. The technology of DBS has also improved, and both the electrode and their batteries are now able to selectively stimulate the targets and avoid the nearby structures that shouldn't be stimulated. It is an interesting concept you might hear from your doctors when they explain the DBS systems to you. In the old systems depicted on top panel, the electricity shines around the shaft of the electrode like light around a candle. Indiscriminately, it can stimulate both a sweet area, that is the target that we want to stimulate and get our benefit, and can go to a sour spot, which should not be stimulated. But if the electrode is placed in this location, cannot discriminate between these targets the same distance away, so we might have some side effect because of the stimulation of this sour spot. However, with the newer technology, they have managed to divide this continuous electrode around the shaft of the electrode into different segments. So 3 segments around the shaft of this electrode now enable us to shine the electricity in a particular location and avoid this bad or this sour spot, this nearby structure we shouldn't stimulate, and only focus our stimulation on the desired area, like a lighthouse, like a beacon that can adjust its light and shine it only in one direction. So we have this newer technology. Even with the old technology, we have shown, not we, the field of medicine has shown that DBS in patients that have been chosen well for this procedure does better than medical therapy alone, meaning that if they have motor fluctuations, they have resistant tremors that medication has not helped completely with, or have side effect of the medication, and if they don't have the criteria that we mentioned, good candidates for DBS can improve their quality of life over medical therapy alone in about 80% of the time. And many clinical trials, double-blind, randomized trials have shown to be the case. So that concludes the treatments that we have for motor fluctuations. To wrap up, take-home messages from this presentation is that Parkinson's disease is a very common neurological disease, and it can cause motor and non-motor symptoms. Levodopa alleviates motor symptoms early on, but after several years, symptoms can fluctuate. And despite having benefits from levodopa, they can cause off periods and dyskinesia. Treatment of motor fluctuations include longer-acting levodopa medications, fast-acting rescue medications, addition of other PD medications that are longer-acting, and more advanced treatments for motor fluctuations include use of continuous levodopa infusion, Duopa, to an external pump, and deep brain stimulation. So that concludes my presentation, and I appreciate your attention.